If you've ever had a knee injection that didn't really help, this may be the reason. It may not have been the medicine. It may have been the location of the injection. Most knee injections are performed by placing the medicine into the joint cavity. This is the standard intra-articular approach, and it is effective for many patients. The medicine spreads throughout the synovial fluid and eventually reaches many different structures inside the joint. However, that does not necessarily mean it reaches the tissue that is actually generating the pain. To understand why, we first need to ask a simple question. Where does meniscal pain come from? Many people assume that pain comes from the torn part of the meniscus itself. In reality, the inner portion of the meniscus has very little blood supply and very few sensory nerves. The painful tissue is usually found at the outer rim of the meniscus. This outer margin is covered by a thin layer of synovial tissue called the perimeniscal fringe. Within this tissue are small blood vessels and sensory nerve fibers. When the meniscus is injured or degenerates, inflammation develops in this region, and these sensory nerves become sensitized. This is where pain is commonly generated. The sensory nerves are also not distributed evenly. They become concentrated around the anterior and posterior roots of the meniscus, and clinically the posterior root is involved much more frequently than the anterior root. This anatomical arrangement changes the way we think about treatment. Instead of placing a large volume of medicine into the entire joint cavity, it is possible to place a much smaller amount directly around the perimeniscal tissue, particularly near the posterior root where the sensory nerves are concentrated. The purpose is not to treat the whole joint. The purpose is to treat the tissue that is generating the pain. There is another point that is equally important. Many MRI reports describe meniscal extrusion or meniscal bulging, and patients often assume that this is the source of their pain. In many cases, it is not. Meniscal extrusion primarily represents a loss of mechanical function. The circumferential fibers of the meniscus normally resist compression and distribute load across the knee. When these fibers fail, the meniscus gradually moves outward beyond the edge of the tibia. As extrusion progresses, the meniscus becomes less effective at protecting the articular cartilage. The clinical importance of extrusion is therefore not simply pain. It is the increased mechanical stress placed on the cartilage over time. For this reason, treatment may have two different goals. One is to reduce pain by treating the inflamed perimeniscal tissue where the sensory nerves are located. The other is to improve mechanical support when the meniscus is no longer functioning normally. These are related problems, but they are not the same problem. Understanding the difference helps explain why patients with similar MRI findings often have very different symptoms, and why the same injection technique does not produce the same result in every patient. If you would like to explore the anatomy, ultrasound findings, and injection techniques in greater detail, I discuss them step by step in my previous lecture series. Thank you for watching, and I will see you in the next video.